It's a pleasure to be here. I realized that I have an hour or more on each one of these topics. So I'm going to try to give you the highlights from the science to the bedside, as it's called, or science to the clinic. I'm going to try to allay your fear about using a ketogenic diet. If you're new to the field, you're studying it, you ask your doctors down the street that don't do that. I want to allay your fears. We need more research. At the end of the talk, I hope to make you just really comfortable to use this kind of approach, unless there are medical problems, and I'll go into that. So I started in this area not by any personal experience like many of you have had with it, with a medical problem being fixed. It was out of listening to my patients doing this, seeing that there was a need for something different as an internist. And so I became an obesity medicine specialist and just ended the presidency of the largest obesity medicine specialist organization in the world, called the Obesity Medicine Association. So it's my pleasure to be here and share with you my knowledge, and I hope you have a great meeting, and I hope this will, again, take away your fear of this approach. My disclosures include some books, consultancies, and early stage companies, and I haven't been able to quit my day job yet. What is the definition of a low-carb ketogenic diet or a ketogenic diet? I think the first thing that came to me was, is it safe to study low-carb diets and to use them? And so when you look at the evidence about what humans need to eat for, in terms of macronutrients or carbohydrates, the lower limit of dietary carbohydrate compatible with life apparently is 0, provided that adequate amounts of protein and fat are consumed. And this is probably the most unbiased source of information that we have, the Institute of Medicine. The minimum amount of exogenous and endogenous carbohydrate is dependent on the brain. So when you're a carb eater, you're a carb burner, and your brain uses carbs. When you're not a carb eater, you're a fat burner, your brain learns how to use fat and ketones. And in the ketones. And, after keto adaptation, about 80% of the central nervous system energy can be derived from ketones, leaving 20 to 28 grams of glucose per day. And this is an estimate from what I'm going to say is kind of the old data. This needs to be confirmed with new methodology, but that's the best estimate we have. And because the endogenous glucose production rate is really pretty high, there's really no need to ingest glucose or carbohydrate because the body can eat it all. In my clinic, I'll say, think about the wolf in the wild, the lion in the plain, that really they're carnivores, they eat no carbohydrate, and their metabolism is just fine. So we're pretty close as humans to that kind of metabolism. So how do you define low-carb diets if it's okay to study them, and if you can take carbohydrates down to 0 for the day? In the paper, the American Journal of Clinical Nutrition 2007, we put out a working definition of, compared to the typical American diet on the upper right-hand corner, of about 300 grams of carbs a day. A low carbohydrate diet is defined as about 50 to 150 grams per day. And then when you get below the ketogenic threshold, the 50 to 20 grams of carbs per day, that's called the low carbohydrate ketogenic diet. Now this is a moving playing field of definitions because now we have blood and breath measurements of ketones. And so I put down here the Steve Phinney and Jeff Volek say that we estimate the nutritional ketosis being 0.5 to 3 millimolar in the blood. But this is kind of a new measure and it's evolving. And so for me, I was reassured that it would be okay to study these different kinds of diets and make the macronutrient range of carbohydrate go from 0 to very high without concern for the patients or the study subjects that I was having. Now, enter in all the different terms, and I think the best measure in terms of ketogenesis to follow is the amount of carbohydrate grams per day in the diet. And now that's a working definition. But that will give you a way to look at all these different popular diets, different names, and its relationship to the ability to have ketones. Because carbohydrate and insulin is so potent at reducing or eliminating ketones. So what is a low-carb diet? If you've never followed it, we talk about good carbs and bad carbs, sure. You could say there's no junk food. Your carbs are from vegetables. It's a big, broad sweep. You could tailor a diet toward your individual population. I live in North Carolina and have an approach that has foods that are comfort foods in North Carolina. This was a study done by Jay Wortman and Steve Finney, and I played a smaller role in it. And this was documented in the Canadian Broadcasting Company documentary called My Big Fat Diet. And you can see in North Carolina on the upper right, we don't have rabbit, moose, frequently, but in that part of the world they did. So anyway, you have pretty much an unlimited amount of meats and eggs and fish and chicken is how you define all these things. It doesn't matter, put it on a list and people can choose it. And because the hunger goes down, people eat less, they lose weight if they're using it for weight loss. You have some salad greens and vegetables. There's a limited amount of cheese, mayonnaise, cream, things like that. Because those are high calorie things, we limit them explicitly. So this is one way to teach a ketogenic diet. People come back after a week or so and they're eating different variations on that theme. You might have eggs and bacon for breakfast or sugar-free yogurt with berry slices. You might have chicken Caesar salad or a fast food burger without a bun. You might have snacks or you're not even hungry for snacks. Did you know you don't have to eat 3 times a day? It's all right not to have breakfast if you're not hungry. I mean, it's just a different mindset. But I thought okay, so you have to unlearn all that stuff. So individuals choose foods from a list of very low glycemic or no glycemic foods, and you advise a multivitamin, and you're pretty much set. It's pretty easy to implement. It's really nothing new. First described in 1863 by William Banting in England. We talk about the history of using this, and it was really the primary method to help people lose weight until everything got messed up in the mid-1900s. And that's a whole nother lecture. But what you'll see for weight loss is typical response is kind of like this from the SHI study in Israel, where you have an initial weight loss and then a regain of some weight. This is an intention to treat analysis, means that you include people who aren't even following the diet. And in my clinical experience, what happens is actually the blue line, which is the low carb group compared to other types of diets, continues to go down and stays down in a clinical setting. So there's a big disconnect between academic publications and the clinical world, obesity medicine world, where you're actually throwing out all the tools that a doctor has. And I'll show a little bit about that today. But this is what you'll see in the mainstream publications. Now, not individual publications anymore. Here's the list of meta-analyses looking at the numbers of studies for the treatment of obesity. This is nothing new. It's been used a long time. There are lots of studies showing the 5 to 10 to 15% of weight loss at a year, which is comparable to a drug. My colleague Will Yancey compared a low-carb ketogenic diet to a low-fat diet with orlistat, which is a medication for obesity treatment, and the diet was as good as the drug in the diet. So the case is closed. This works for obesity. When I was faced with the initial concerns, it was a concern about safety. Everyone knew it could work, but is it safe? And the last thing about obesity, in the obesity medicine world, we don't talk about weight loss, we talk about fat loss. So actually obesity is a disease of too much fat on the body. And now with CT scan documentation and other newer modalities, it's pretty clear on the upper right-hand panel that the low-carb diet and even a low-calorie diet with other macronutrients leads to fat mass loss. So it's pretty well documented that you can lose weight, you can lose fat mass weight. And having talked to many of you already, many of you know that, but the data shows that as well. And when you're trying to talk to other doctors and policymakers, they want to see the data. And so the concern about the diet really came from what does it do to the blood cholesterol, right? But all that fat you're eating, it can't be good for you. So for me in 1998, that was my response. But it may be the response of your doctors, dietitians, health policy people today. And so I want to bring you through the last 18, 19 years that I've seen, okay? So the concern about LDL cholesterol as the only thing for metabolic risk has changed for cardiovascular risk. So now we talk about the metabolic syndrome in cardiovascular disease. The metabolic syndrome confers twice the risk of developing cardiovascular disease over the next 5 to 10 years compared with individuals without the syndrome. It confers a 5-fold increase in risk for type 2 diabetes. It's defined by an elevated blood pressure, abdominal obesity, insulin resistance, elevated plasma glucose, and the atherogenic dyslipidemia. And the atherogenic dyslipidemia is elevated serum triglyceride and apolipoprotein B, increased small LDL, small low-density lipoprotein particles, and a reduced level of high-density lipoprotein, or HDL cholesterol, the good guy. So the triglycerides are high and the good cholesterol is low. That's the pattern you'll see in the blood with people who have metabolic syndrome. Add in the increased abdominal girth, that's the extra weight, or you could use a BMI as a proxy for that as well. But so this was the saving of the low-carb diet, in my opinion, was the shift from just looking at LDL cholesterol to the metabolic syndrome. This happened over the last 10, 15 years, and there's really not, Jerry Reven was talking about this, Professor Reven, for much longer than that. The mainstream didn't acknowledge it. It's now being acknowledged. It's even part of guidelines as a footnote, but this saved the low-carb diet because the effect on triglyceride and HDL is unbelievable. So now going back to one of the meta-analyses, not just one independent study, but you line up all of them together, and the recurring theme is that the low-fat diets lower LDL cholesterol, that's the upper panel, and low-carb diets lower the serum triglyceride better than low-fat diets, and then raising HDL as well. Shown on this panel, this is a summary by Jeff Volek, who with his crew from the University of Connecticut, now at Ohio State University, are really at the forefront of collecting data on this kind of dietary pattern. So if you look on the far left, body mass goes down, and this is comparing to the low-fat diet in the lighter color, but all of the parameters of metabolic syndrome basically get better. Triglyceride and HDL. HDL is kind of the lone one up there where you can see the orange bar going up, which is the very low-carb diet, ketogenic diet, compared to the low-fat diet. So the low-carb diet reduces cardiometabolic risk by raising the good cholesterol and lowering triglyceride. The low-fat diet lowered cardiometabolic risk by lowering the LDL cholesterol. It just works by a different method. Now, if you're coming at this from the basic science level, Jeff Volek and his group also have a great summary in the Progress in Lipid Research 2008, which shows the liver metabolism changes, the increase in ketone production, the reduction in VLDL, and triglyceride production in the liver. In the clinic, I'll talk about the foie gras effect. If you want fatty liver, you feed geese corn. In the old days, figs. You feed carbs, basically, you get a fatty liver. Happens in humans as well. So if you want to lower fat in the liver, you lower carbs in the blood, or in the diet, okay? You'll hear a lot of people, fat in the food, fat in the liver, reduce. No, it doesn't work that way. Now, just to show the data in one study on the HDL going up, I didn't show that yet. So here's a figure from the Shy paper with HDL cholesterol going up better than the other types of dietary approaches. So in my world, I say this works as well or better than other approaches. It's not that other approaches can't work. And that's the best, I think, the political compromise when you're talking to other people who are still believers that there's only one way to do things, because there's clearly not one way. So in that Shy study, the workplace diet trial or direct study in Israel, this is one of the best hard endpoints that is available in a publication about the carotid intimal thickness going down in a longitudinal study, a randomized trial. It didn't matter what diet people were on. If they followed the diet, they lost weight, and their blood pressure went down, the carotid intimal thickness got better. And this even, the subsequent analysis, it was the blood pressure that was the most important thing. And have you ever heard that it's important to control blood pressure? Yeah, so maybe that the dietary approach is not as important as the outcome of weight loss, blood pressure reduction. Again, this is kind of the macro view. Again, one of these, I think, pioneering studies with Cassandra Forsyth, Jeff Volek, and Steve Finney. What's going on in the blood? So there is some evidence that saturated fat in the blood, not the diet so much, but the blood is related to heart disease. And so they had predictions, but then followed it up with the data collection, showing that the saturated fat level in the blood is actually lower when you're not eating carbohydrates. So the higher fat diets lead to a lower saturated fat level in the blood. And well, why is that? Well, it's because you're burning it. So when you're not a carb eater, carb burner, you're a fat eater, fat burner, you're burning the fat on your body, you're burning the fat you eat. The saturated fat is handled very differently. And this, I think, is going to be one of those papers that gets cited over and over and over because everyone thought that eating more saturated fat or more fat in general would lead to worse metabolic outcomes. But it doesn't even lead to the intermediate outcome that everyone said, that saturated fat in the blood would be higher. So this is one of those groundbreaking papers. Please take a look at it. So what about diabetes? Well, 100 years ago, doctors used the ketogenic diet, low-carb ketogenic diet, the Allen method, the Osler method, however you want to say it. They used it for the treatment of diabetes. Before there were any drugs, before insulin was discovered, and they were just checking the urine for glucose, they found out pretty quickly that this is just the same information on from the Osler textbook of medicine on the previous slide. 10 grams of carbohydrate for the day. I'm very curious as to why they used alcohol 15 grams a day, and so are many of my patients. Probably because it can lower the glucose production from the liver. But so basically, this is pretty similar to that list of foods you saw that I use in my clinic. And careful, some patients don't want to be told that this is nothing new. They want it's something new, put a new name on it. But it was actually really helpful before there were any drugs. It's a whole nother lecture on how that all got messed up. Drugs came along. People need carbohydrates. They love them. And so that all just was lost. The way I look at one pathophysiologic look at diabetes is like this. So that type 1, which is, so remember, diabetes is defined by a higher blood sugar, hyperglycemia. You could have no glucose clearance out of the blood. So you're putting glucose into the bloodstream, absorbing it from the food, and you can't clear it because you have no insulin, and the treatment is to replace the insulin. It took people who were starving and dying young and let them live. Imagine the confusion when you actually measured it in adults and the insulin was high. So the type 2 diabetes, adult onset, if you have some insulin in there, it's usually associated, but not always, with obesity. You have a high glucose input, and then you have reduced clearance as well. So the main things in the nutrition that lead to high glucose input are carbohydrates, protein a little bit, but not much, and fat has no glycemic effect. If you look at the list of glycemic foods, fat isn't on them, on the lists, because eating fat doesn't raise your blood sugar, blood glucose. And then, so what would be the option for treating? Well, a low or no carb diet to lower the input, or adequate protein, not high protein, and then high fat would be perfect. So this is basically the slide from 100 years ago. Measuring the urine glucose, so we can actually do better than they did, I think. But then the reduced glucose clearance from insulin resistance, which is the term used to explain why the blood glucose remains high, even though there's a lot of insulin around, is actually treated by weight loss and abdominal fat loss, more specifically, and exercise to a little degree. But so in a qualitative way, I put a 5+ on weight loss. I can help people fix diabetes without any emphasis on exercise at all. So that's another paradigm shift. Everyone said you have to exercise. You can't lose weight without exercise, and don't even try. And that's just totally wrong from the obesity medicine standpoint. So so type 2 is very different than type 1. And this is kind of the big picture view of what works. There's a 1-2 punch with a ketogenic diet because you're cutting out the carbs and people are losing weight if they have extra weight. In fact, that was a criticism on our early studies is, you're doing too much. We don't know the mechanism. But they all got better. No, it doesn't matter. You don't know why. So it doesn't fit into a organization that wants to know the mechanism, and that's where most of the money comes to do big studies. And that's why it's been difficult to get these kinds of studies funded. So when the old paradigm of fearing fat in the food was prevailing, the studies that were done and published about diabetes and low-carb diets hit this wall of percent carbohydrate down to 25 to 50, 60. So a low-carb diet was defined by 20% carbohydrate, which you can't have ketogenesis at 20% of your calories as carbohydrate. But in the words of several of these investigators, they said, well, if we lower the carbs more, what are you going to do? Give them fat? We can't do that. Okay, so you see these studies down to 2004 showed some improvement with lower carb diets, and great, but how much was the improvement? So you got to know what is the magnitude of effect, and you can even do better, perhaps. So one of the best studies, I make my students and residents read this. Gunther Boden did a study where an inpatient ward with type 2 diabetes and knew exactly what people were eating. You tell people to eat their regular food intake. They have this kind of glucose and insulin pattern. You let them have ad lib, low carb. So unrestricted amount of food, hunger goes down, they eat less, and they pretty much matched what they needed to eat based on their size, which was pretty neat. That was, of course, this is like basic physiology that had to be shown in a recent paper to just convince people who didn't get trained in physiology, I guess, that if you have carbohydrate in the food in a meal, the blood sugar and insulin will go up. But if you take carbohydrate and out of the meal, you don't have a postprandial rise. So I hear other domains saying we want to lower that postprandial rise of the after the meal rise of blood sugar somehow. That's where the disease manifests. Well, why not eat less carbohydrate? So it's just like a blind spot, or people are just in a different paradigm. They can't understand that. So now we talk about insulin-reducing diets, keeping the insulin down as a way to induce and keep ketones around, and ketogenesis. I like this paper again. That's the Boden paper, because they showed, that even though we say nothing about calories, people eat fewer calories on a low-carb diet. And this is generally true in the outpatient setting, as I'll show you. So it's not that calories don't matter, and I just get past that. Don't even get into that, because it's just what's today? It's a rabbit hole. So calories matter. We just don't count them is the best way to teach this. And really, on this study, what happened was people just ate less carbs. They ate about the same amount of protein and fat in terms of quantity. And there's going to be a lot of variation in the individual, what they choose to eat. So our contribution to the diabetes world, I thought by 2008, everyone would be prescribing a low glycemic diet for diabetes. So we designed a study randomizing people to the low glycemic diet or the low carb ketogenic diet, published in 2008. And so there were 49 in the low GI, 48 in the low carb ketogenic diet. These folks had a hemoglobin A1C at baseline of 8.3 and 8.8. They were on different medications, so it was a medically supervised kind of dietary program. And in individual results here, and then in average, the low GI diet helped and it lowered the A1C by 0.5%, which is good. It's a drug-like effect. And the low carb diet works better, lowered the A1C by 1.5%. So a lot of these approaches can work, but maybe we can do even better. Now, through the years, people call this a proof of concept study. It's not enough to change policy and all that. And so if you're going to try to do that, you probably need larger studies. Thankfully, those are ongoing now. And but this, to me, was good enough evidence for safety, and also in me learning how to reduce medication so that I could start a clinical program, which I did 10 years ago. And so this is back to the study. In the low GI group, there were 3 people who had reductions in insulin. And here's the insulin at baseline, insulin at 24 weeks, and then the A1C difference and the weight difference. And you can just see that they were the same people starting, but there were only 3 in the low GI group that had reduction in insulin, and there were 1, 2, 3, 4, 5, reduction in elimination of medicines in the low-carb ketogenic diet group. Will Yancey, my colleague at Duke, who is continually funded through the VA to study low-carb diets, Veterans Affairs Administration, had to come up with the first measurement of medication reduction, because there had been no treatments that really formalized that. So there's a standardized questionnaire now, or assessment tool, that shows not only is the A1C better, but we had this much incremental reduction in medication. And then the metabolic syndrome parameters in this study showed the same general theme, that the HDL cholesterol goes up more than a low GI diet, even among those with diabetes. So since this time, the last few years, we have a resurgence of studies looking now at carbohydrate grams per day, 90, 58, 57, 76 grams per day. Ours was 20 grams per day over a 6 to 12 month period. And what we're seeing is that, lower the carbohydrate grams, and the A1C is lower because the A1C is a reflection of the blood glucose, and you have less input into the system, your blood glucose will be lower. And this was summarized in a chapter in a book that Susan Massino edited, largely came from this conference last year. So thank you so much for having that book done. So let's go to the clinic. Imagine you're coming to Duke University, the Lifestyle Medicine Clinic, and you're referred a patient from across the hall, the internal medicine side, and they tell you, this guy's got a high, just diagnosed with diabetes, A1C is 10. All the guidelines say this person should be put on insulin or some other medication. My colleague and friend said, I just told him to do your diet, and now he's showing up in your office, okay? So I'm following up, tweaking, making sure he's doing low-carb ketogenic and feeling well and losing weight. And so here's his weight loss after starting the ketogenic diet. He's down, about 30 pounds. And here's his A1C. This is a clinical setting, so the last A1C we have was 5.9, 4 years before. And he normalized his blood glucose, which is just really summarized in the A1C, so we're really talking about the same thing. He has normal blood sugars and without any medication. It goes against all the guidelines, and that's okay. The guidelines give you basically what we typically see out there, which is an epidemic of diabetes and obesity. In my clinic wall, welcome to the clinic, I teach my patients to check their blood sugar, and I also ask the medical students, residents, doctors, endocrine professors, how much sugar is there in the bloodstream? I don't know. Why would that be relevant? Well, because your diabetes is a disease, a disorder of a higher blood sugar. How much is in there? Well, I don't know. Well, so it's plain as the finger stick in front of them. You calculate out with what, in my experience, is like middle school math. So most medical students have forgotten it. And basically, there's a spoonful of sugar in the entire bloodstream. So this picture's on the wall, and people come back and go, well, then why would I want to be eating sugar? I have diabetes. And yes. Enough about that. We got to go see these patients. So here's a screenshot of my clinic panel in just the last few weeks. It was before I went to another conference. I thought, I'm just going to show you what happens. It's a long way to see me in Durham and to go around, so follow me, okay? We're gonna go see, we got 25 people to see today. I see some other obesity medicine specialists in the audience here. pretty typical day in the obesity medicine clinic, but I'm not using medications like many of the other docs. I'm just using the low-carb diet. First visit here is like an internal medicine specialty. You go in, you talk, you chat them up, you develop rapport. You know, gosh, Dr. Westman doesn't have horns. And everyone said he was evil. And well, no, actually. So they come back for a teaching class. It's a 1-hour class that I do that's based on some handouts, pretty simple. I had people sleeping in the class, and at the end I'd say, just stated the foods on this list. And, oh, okay. And, you know, and I have rocket scientist professors come in and they want to know why their blood sugar is 98 and not 96. And I say, I don't know. So teaching class, return visits here in column format, and we got to go see this next patient, please. Okay, so really, this is a clinic day. This person lost from 302 to 258 pounds. The cholesterol levels down at the bottom here, the most remarkable thing that drugs cannot do, the HDL went from 44 to 62. That effect is amazing, and it keeps going up over time. So let's see, this person really didn't lose much weight. So for diabetes, A1C is already 5.9%. You know, it's not a perfect, sorry, you people who want perfection in a body of imperfection, you're gonna get values that are not perfectly, and please don't look at these numbers I had at last meeting, but no, so this is a bioimpedance measure of body composition. It's not a great measure visit to visit, but for trends it is. So I don't ask people to write down what they're eating at home. I just have them fill out a qualitative food record when they come back, make sure they're getting adequate protein, they're not having many carbs. And this person is off metformin with blood sugars now, a minimum BG blood glucose of 80, maximum 100 with home readings, off medication in just, which would be, usually it's about a month, so within a month. So pre-diabetes, you know, that's easy. The diabetes on pills, that's pretty easy. This fellow with blood pressure, you got to monitor it. So you got to be a doctor if you're going to handle the diet with people with doctor diseases, so be careful. Medications can become too strong, and so this person's A1C went from 8 to 5.9. It's the real world. He went out and got a new prosthetic limb, so he didn't do any exercise. He got a new limb and his weight went up 3 pounds. That was a head scratcher because he came back, his weight was up, he was doing everything right, and he got a new lower leg. Welcome to the real world. So it's this person, you know, God, I can scan this and go, not so good. Crackers, cookies, chips. A clinical setting, all people come in, they're writing down at home what they're eating, and they'll circle all the wrong things. So a lot of this is teaching it. A lot of this is teaching over and over, unlearning what people have learned for many years. So the other thing, if the weight is going up when I go in, that's not a good sign. Although this person is still down 54 pounds from the very beginning. So 3 years into it, down 54 pounds over the holiday, you give people a break. So again, this is the clinical application of the science that I've shown you so far. Just some other, you know, it started at 298 pounds, now has maintained now at a BMI of 27, a weight of 206, still losing weight over that period of time. A lot of people are coming to me, it's a 4 to 6 month waiting list to see me, they're already starting. And I just help continue them, or I just bless them to tell them, yeah, it's okay not to worry about what their doctor said, and sometimes I'll send the doctor a Valium prescription for fun. It's a joke. Because actually the nervousness of the doctors is a big impediment for the patients who are confused. And so just be ready for that. You're going to run into that even today. 290 pounds down to 229, and waistline as well. I forgot to mention that. That's part of the metabolic syndrome. I mean, you know, don't really need exercise, but it's okay if you do. And this one, okay, now let's get into insulin. Okay, a little bit. So here, remember, here's the minimum, maximum blood sugars. You can bring people in with their glucometers, their Dexcoms, their whatever, or you can just not. A1C from 7.8 to 5.6, off 30 units of insulin, off or reduced medication on so still on metformin. This is 4 months into it, not maybe 10 pounds of weight loss, and the blood glucoses are better, as good or better than before on less medication. That's also another common mistake is they'll go back to the doctor and say, well, your blood sugars are still high, and forget that the blood sugars were even higher when they were on medication a year ago with them. Just because it's the paradigm. It's what doctors do. They see it, they try to treat it. So add up all the insulin units. In the class, we do a total cessation of carbohydrate to 20 grams or less. Well, so almost total cessation. Carbs are stopped here between the first 2 visits. You reduce the insulin by 50% if they have blood sugars in the hundreds, otherwise they'll have hypoglycemia. So you reduce the insulin to avoid hypoglycemia, and if they're checking at home 2 to 3 times a day, if the blood sugar is under 100, they don't take insulin, okay? Doctor's advice. Some of my patients don't even know what insulin does. So now you apply this to a population of folks who you inherit the education and you inherit the medical treatment that someone else has initiated. And basically we're taking people down from this precipice that they don't know how to get down from, okay? This person off 100 units of insulin in 6 weeks, really with no weight loss. This is just the effect of food, just the input of food into the system, treated with insulin. These are all individual patients, okay? 80 units off in a week, blood sugars as good or better than before. Oh, and by the way, they lost 28 pounds by 6 weeks. So you cheated. People say, well, no, it's part of the program. So the ketogenic diet does lots of different things, including glucose reduction and weight loss. Another patient, long-acting insulin, stopped in 2 weeks. Oh, down here for detail, insulin can come in lots of different forms and shapes, and now they've even created a 500 unit per ml as opposed to the 100 unit per ml, with the idea that by giving more insulin, you'll fix the underlying type 2 diabetes. You can't fix insulin resistance by giving more insulin. And this is the obesity medicine world. You need to treat the obesity, the underlying abdominal fat, inflammation, whatever the mechanism is, okay? So off insulin. So, another patient, 100, it's like, okay. This person was on 3 short-acting shots, 1 long-acting shot. Doesn't matter if it's Lantus or Levemir, but boy, you better say the exact word, because patients are so scared about the medicine, they need to know just that word. So if you just talk about Levemir and they're on Lantus, I'm not on Levemir, I'm on Lantus. It's really pretty much the same insulin, although with the shading of all, and the marketing today that you get about insulin, this one's better than the other. Just add up all the units. 100 units, cut it in half the first day. This person I didn't cut in half because the blood sugars weren't in the hundreds, but I had to reduce it. So because I've seen these slides replicated without the comment here, I put this on every slide. So that you have to be careful to reduce the insulin immediately when you cut the carbohydrate down, okay? Again, 170 units off within a week. This person had been on insulin for 10 years. Oh, and the ADA recommendation, which is 45 grams of carbohydrate per meal. So one of the other places where I lose patients' confidence and then they come back and I reorient them is the hospital setting. They go in, they're treated, they're diabetic, they get 45 grams per meal, which you're putting into a system that has how many grams in the blood? Roughly 5 grams. So it makes no sense, it makes no sense. 25 years of insulin, down here on the left, off in a month. Now I have people, but it's taking so long. You had it for 25 years. So the other phenomenon you'll get is it's not happening fast enough. Well, you're down 10 pounds in a month and you gained, well, that's still not fast enough. It's okay, calm down. That's all the rapport building on it. So this person's down 30 pounds in 20 weeks off insulin with blood glucoses as good or better than before. This is pretty amazing. 275 units stopped in 4 weeks. Our record is 500 units per day. Now off down to 75 units at 10 weeks. He's still on, I've seen him since then, he's still on about 50 units a day. He's pretty sedentary. I mean, he was going around Walmart in a walker. Now he's walking, and he's thrilled. Of course, he's paying a lot less medicine for insulin, although a lot of people pay nothing on insulin because it's paid for by their insurance. So he and his wife come in, they're both doing great, and they feel great. And just the point being here is he's not off insulin. So the insulin resistance, which we think is from the obesity, abdominal obesity, is still present. And he still has 100 pounds to lose. So you'll get people who say, well, you had 6 months, you didn't fix it. Well, but wait a minute, this was something that took years to develop. So just give it a chance. In a world that you could send them to surgery because, well, even certain weight loss surgery, even now with the 10-year view, people regain weight if they're not taught about the lifestyle, even after major bariatric surgery. So the diet is really, really important, even with these other manipulations. So insulin still can be required after 6 months if you're just trying to get the blood sugar controlled. I had someone say, well, but you don't have A1Cs on those slides. They don't count. Well, okay, here's some A1Cs. The A1C here in blue going up to above 7, and the weight going up to 300 pounds. Now on the low-carb ketogenic diet, off medications, the A1C is in the 5s, which would be thought of as non-diabetic or not requiring medication. Likewise, this is the internist's dream. It treats all of these things. It's the pharmaceutical company's perhaps nightmare, but don't worry about them. Don't worry about them because they have a lot of other irons in the fire and still selling a lot of stuff. But diabetes, hypertension, heartburn, that's the other. So diabetes medicines go away. Heartburn medicines can reduce or eliminate them pretty quickly too. Checking blood sugars, low-carb ketogenic diet, A1C now, I'm sorry, on the other side, under 6, weight down, off all medications. After 10 years at Duke, I'm running what's known as the clinic of last resort. Okay, I call it that. People, they've been on every diet, twice, and I'll say, you haven't been on this diet with me. Oh, okay, this guy seems to be confident. So we've treated people who were on medications that would make everyone gain weight. Steroid pills, steroid shots, nasal steroid sprays, and they lose weight. We treated type 1, including people with breastfeeding mothers, and type 1 grit, the world changing by the internet. Type 1 grit is a Facebook group with a couple thousand people with type 1 diabetes doing low carb. R.D. Dykman set that up. I met him last year. It's a great resource, great place. I did a consult on Facebook. I got on Facebook with someone in the clinic and chatted with someone. Oh yeah, you do that? And wow. So I asked users of the diet with a certain disease for help in treating my patient. That's pretty cool. Inflammatory bowel disease, the heart failure. So I have people who are they're on the transplant list and they have these pumps in their left ventricle because their heart doesn't work. But they're denied a heart transplant. Well, there's a list, there's a prioritization. Not everyone can get them, and they have to be low enough in weight. So the heart surgeons and cardiologists send me people to lose weight so they can get on the transplant list and get a new heart. I don't use medication. Most other doctors for weight loss will put them on medication, and the heart doctors don't want their patients on more medications. So these are pretty complicated. It's hard to get sicker than this, especially if you add in to the heart failure, the diabetes, and all that. Lymphedema, lipedema, I'm giving a conference talk later this spring. Leslyn Keith, who's a occupational therapist, keto person, did a study, got the award last year for lymphedema, lipedema. The word on the street there is nothing works, but actually that's because no one considered taking the carbohydrate out of the diet. It works really well. In the last couple of years, with these new drugs that make the urine leak out of the kidney, it can cause ketosis. Seen actually one patient in my clinic. Why? It was in the hospital because of ketoacidosis. So what happened? I haven't seen this in 10 years. my diabetic doctor put me on this diabetes drug. It's a new drug. It's got a lot of press. You'll see it on TV. It actually has the concern about ketoacidosis on there. Don't use the ketogenic diet don't use this drug if someone's on the ketogenic diet. It's not the diet's fault, it's the drug's fault. And you're going to see people blame the diet for all sorts of things. It's not the diet's fault. So if I can bring you up to speed from 1998, if you're just looking at this for the first time, for me, that was 1998, to 2017, ketogenic diets, low-carb ketogenic diets, keto diets, paleo, there are lots of different forms, lead to a reduced hunger and spontaneous reduction in caloric intake. That's why they're good for weight loss. Ketogenic diets lead to improvements in obesity, metabolic syndrome, type 2 diabetes, type 1 diabetes. Ketogenic diets can be used in a clinical setting by trained practitioners and be used as a healthy lifestyle. Ketogenic diets appear promising as a therapeutic option for many chronic medical problems. Many will be talked about during this conference. Further research is needed to determine the effect of ketogenic diets on hard endpoints of cardiovascular disease, heart attacks, and strokes, and we're working toward those kinds of studies. Now the problem is just getting agencies to give the money to get that kind of study done. And we're very hopeful that'll get done. From what I see in the clinic, I pulled out an old slide I showed in May 2004 of here we are on the USS Lowcarb. My first study, I said, I don't know where we're going, but I'm on the same boat with you. Like we're on the same plane, and I'm not going to let it crash. I don't want that to happen. So I've been looking out the crow's nest, and everyone else said we would fall off the end of the earth. That hasn't happened yet. And other people said that we would, find riches and Taj Mahal, and we're hoping that happens. We're somewhere in between. But that that was 13 years ago when that is a slide that I gave. I kind of feel like this should be the end of a computer graphics movie with the cast of thousands, or not the cast, but the contributors of all the people that have been involved, and it's not the usual people you want to hear from. I mean, it's scientists, clinical practitioners, authors, journalists to get the intellectual change, the mindset. It's grassroots movement. It's people doing the change and then spreading the word in a system that just doesn't hear and listen. And then in a internal medicine world where we don't allow drug reps into our building. We're so anti-pharma, anti-corporations. However, we want companies in this space because, in fact, most medical education is funded by companies. Sorry, but it's true. The graduate medical education, grand rounds, things like that. We need companies involved that will give money to help this area grow, do more studies, help with education, and I assume the clapping was, that specific type of funding. But thank you so much. I hope you have a great conference.